Welcome to ANZICS Meet the Expert podcast series, that is Intensive Talk. In this podcast series, we meet with experts around the globe to discuss various challenges that we are facing as a community and understand how experts look at these problems. Hi, my name is Swapnil. I work as intensive care specialist in Sydney, and today it's my honor and privilege to welcome Professor Maurizio Cecconi from Italy. Now, this name doesn't need any introduction. In fact, first of all, I want to start by saying a big thank you to Maurizio for his clear message on the JAMA podcast, where he gave a one message to the entire world: get ready now. And I think that message has actually shook entire world and made us to prepare for the pandemic that we have never seen before. The second thing I want to say to Maurizio is hearty congratulations for providing a leadership, not just within his ICU, but even as a president-elect for ESICM by organizing a lot of webinars. And that marathon webinar was amazing because it not only gave us insight into the disease process, but also helped us to plan how we are going to look after these patients in other parts of the world. So Maurizio, welcome to this podcast.
Thank you, Swapnil. Thank you for hosting me, and thank you for your nice words. But it's important to remember it was not me. It was a team effort from Lombardy, first of all, and then from ANZICS to decide to try to share as much information as possible. So I was the messenger, but it was really a team effort to realize that what we were seeing here was unprecedented. And we thought that if we were surprised, and I also have experience of previous work in the UK in other healthcare systems, we thought if we are so surprised, we just have to try to share this information as early as possible so that others can get ready. But it was not really about me. It was about everyone realizing we have to convey this message out as soon as possible.
Absolutely. And I think I can only imagine the challenges while providing the good clinical care at the same time publishing a good quality research is extremely hard. And I think you guys as a group did extremely well in both aspects. So first of all, I want to start by asking you, what's the current situation in your ICUs? What are you seeing? Because I think the peak has settled now. So what's the current situation in Italy?
So the situation is definitely better than some weeks ago, but everything has to be put into perspective. I was actually chatting about this with some colleagues from other ICUs in the last few days, and just to give you some numbers, because I do like to talk with numbers. Before our crisis in Lombardy, 10 million people, we had 720 ICU beds open. You would consider this mainly level 3 beds. So the kind of level 2 is provided in mixed areas often in Italy, but to provide respiratory support advanced, those were the beds. At the peak, which we reached roughly on the 2nd of April, we had a total of 1,800 level 3 beds open in the region to provide care for 1,500 invasively mechanically ventilated COVID-19 patients, plus all the other time-dependent pathology, and probably another 2,000 level 2 beds in the other parts of the hospital. So the situation is better, but just to give you an idea, today we are roughly looking at 600, 650 COVID-19 patients that are still in our ICUs. So yes, it is better, but if you think about where we were 2.5 months ago, we nearly saturate our pre-COVID capacity just with what we have now in terms of number of patients. So we are, we're feeling a little bit more, confident that we can manage if there is the next surge. We hope it's not going to be as bad as the first one. There is a big difference now in the sense that when we discovered that we had a secondary transmission on the 21st of February, it takes a bit of days to realize what is your R naught, your RT. So the transmission of the virus is not something that you find out in one day. And by the time we found out that, we realized it was so high that we had to lock down the region, lock down the country. Now we start from a situation where with measures like social distancing and so on, we hope that we can control this a bit better. And funny enough, you're interviewing me today. Today is the day in which in Italy we released the lockdown with some, we restart the society basically, and everyone is very excited. But of course, we are also very wary that we have to monitor the situation very carefully.
Yeah, and I think that's a significant milestone that you guys achieved as a community, that to open that whole lockdown. And I guess that's partially because of the great efforts by all the clinician, nursing staff, and allied health in ICUs and hospitals. So I guess you guys did an amazing job. Now, when you are talking about the numbers, that number is still scary for me, because you're saying that there's still 600 beds which are still occupied by COVID-19 patients in ICU. Now, we all know that longer the duration of stay of patients in ICU, that poses a different challenges to providing the care. Not only the patients who are in ICU, but for patients who are waiting to get ICU bed. What's your perspective on that aspect?
You made a very valid point here. So we know that roughly the ICU length of stay during the peak of the pandemic was roughly, I would say, probably 15 days for ICU patients, of which very often you have the early survivors and the early non-survivors, unfortunately, but some patients that were still staying in our intensive care units. In the last 2 weeks, the occupancy is basically made by patients that are longer to wean compared to the others. So there are patients which we think that there is a hope that we can wean them off from the ventilator, but it is true that it's a minority of acute admissions. It's more about patients that now require weaning from ventilation. So the percentage of tracheostomies is higher now. The approach to these patients is different. It's not anymore about the acute phase. It's about trying to find the journey for them to wean off the ventilation and then to leave intensive care. And this is also unprecedented, because it's not common to see this number of pneumonias in our hospitals. And so all the rehabilitation services, all the pneumologists and the respiratory care services, everyone is restructuring a bit to try to find what's the best pathway now for these patients, which of course, they're going to have many weeks ahead, even if everything goes very well.
Absolutely. And I think you mentioned a very valid point. And even in Australia, we never seen the peak that you guys saw in Italy. We started that discussions very early, whether we should do tracheostomy or not, and how we should approach the tracheostomy. And doing a tracheostomy itself as a procedural, it's going to be a challenge in COVID-19 patient. Its nature of high aerosol generating procedure. How you guys are coping with that challenge, and what's the kind of plan of doing tracheostomies in Italy?
So yes, it is a challenge. However, I would say that I don't consider that part on the patient particularly challenging for the risk for the operator. It seems, at least from the data that we have in the region that we are sharing now, even if not much has been published, is that actually the healthcare workers that have been working on COVID-19 ICUs, because they were aware of the risks, and we were able to provide proper, protective equipment to these people with proper training on donning and doffing, the percentage of healthcare workers that got infected was actually, low compared to other settings, maybe in the community or where you have a higher chance to meet more people and potentially infected patients. So I wouldn't say that the tracheostomy challenge is about doing a tracheostomy potentially in a patient that is that is infecting you, because I think with the right precautions, either if you're providing an intubation or if you're doing a tracheostomy, you can protect yourself quite well. And I think that was our duty as leaders in the healthcare community to pass that message, that the protection of healthcare workers through proper stocking of the proper equipment and proper training and donning and doffing was very important. By doing that, we've not seen a high percentage of infections in COVID-19 ICUs. In Italy, we didn't have many single rooms for ICUs anyway before starting. So the approach was immediately to create cohorted COVID-19 ICUs. That means that when you work in these areas, every patient is considered to be a COVID-19 patient. And that means that you enter with full protections. You don't go out of a room from a patient that is non-COVID and then you go to the other one. So basically, you're fully protected on that. So the challenge for us is not so much on on the protection of the healthcare workers is more on the fact that really the volume of the patients that we're seeing is so high. So we've never had so many patients to wean at the same time from pneumonia.
Yeah, and I think that's the interesting challenge. So just to give again numbers, what's the kind of percentage of patients are getting converted to tracheostomy from mechanical ventilation?
I don't have the number for the region. I can give you my experience so far. If you look at and what I tried to do in my hospital with my team was actually to try to bring evidence for what we knew in the past in intensive care. So, we were not people doing early tracheostomies anyway. I don't think there was much evidence from previous literature on this. So we try not to change too much our practice on the individual patients. The challenges are more around the organization, on the fact that, again, the volume is very high. So we didn't do a lot of trachees at the beginning. We tried to win patients mainly on the ventilators. The challenge is there when we didn't have enough ICU ventilators was the fact that we had to increase our surge capacity, anesthetic machines. And anesthetic machines, they're not as good for weaning. So we kind of stabilized the patients on anesthetic machines, but then we had to do quite a lot of swapping between machines to be able to use the right machine for weaning. That got much better over the weeks because we were able to increase the stock of proper ICU ventilators. So it's not really an issue anymore as if it was at the beginning. So I would say the first few weeks we didn't use as many trachees, at least in my hospital, but I'm sure you will find different practices in other places. Certainly now I am increasing the number of tracheostomies that I'm using to help the weaning for these patients, because again, I now have those patients that have stayed in the unit for maybe 3 weeks, 4 weeks, 5 weeks. And at some point you reach a stage where it's very difficult to manage this just with an oral tube, even if you're good in managing sedations and keeping the patient with a good RAS score and working with physiotherapy and nurses and doctors to try to get out of this.
So that's again interesting point that you mentioned, that you have to move the patients, because the initial images which came out of Italy, that patients getting ventilated in recoveries or post-operative care units, and now you have to move them into ICU with a proper ventilator and proper nursing staff and allied staff.
We actually moved the devices and the staff to the patient. So we actually converted operating rooms. Many of these operating rooms and the recoveries, they still are COVID-19 ICUs. So just to give you an idea, at the peak of the pandemic, I basically was able, with my team and other teams in the hospital, to provide respiratory support, either in the form of invasive mechanical ventilation or non-invasive mechanical ventilation in CPAP for about 100 hospital beds. And before this, I was providing care in about 24 beds for ICU. So, the increase has been a 4 times fold. In some hospitals, it's been up to 5 times fold. But we had to really convert areas. And some of these areas have been shut down and reconverted to COVID-free areas so that we can resume some surgery, we can resume some normal activities. We always kept one ICU, which was a non-COVID ICU. So now we are in that phase. Basically, we are converting capacity depending on where we are with the epidemic. But we have a plan in place to be able to surge again if we need to, and if we see a second peak of what's happening.
That must be really, really challenging. And I can only imagine the impact on the staff. Before we move on to the other sort of question, I just like to get your thoughts on the lung mechanics of these patients. There was a lot of interesting discussion around the phenotypes, and initially when they come, there's some sort of L phenotype which gets converted to H phenotype and is like a proper ARDS. And what are you seeing in your experience, and what are the kind of challenges in weaning these patients in terms of lung mechanics?
Yeah, I'm not so sure we have enough evidence to say that there are only 2 phenotypes for these patients, to be honest. It is true that when you see these patients at the very beginning in the emergency department, very often the striking feature is hypoxia with normocapnia, very often. And when you intubate this patient, it is true that very often the compliance is not on a very low level. But the variety of features that we see in lung mechanics is high. And I think it would be probably a bit too simplistic to say that there are only two phenotypes here. Probably it is a wise approach, and certainly we're seeing this in our patients, not to go too high on the PEEP levels at the very beginning when you stabilize patients, because a lot of these patients may over-recruit if you go on a high PEEP level when they have a normal compliance. But that goes back to individualized therapy, and it is what we should have done even before COVID. Again, I see a high variety of cases. What we are doing in my unit is, if we have a new admission now, we try to kind of do what I would call an easy stabilization at 3 o'clock in the morning, where everyone can try to do something simple. And then we fine tune the PEEP and the ventilation, during the day when there is more expertise around. So I would say, yes, very commonly to see hypoxia with maintain compliance. And then some patients have different features. But again, I wouldn't limit this just to two phenotypes. I would just say you have to look at the patient every day. And probably good practice is to try to assess lung mechanics every single day, at least once a day. In my unit, we had shifts every 6 hours. We still do that. So every 6 hours, there is a doctor takes over from another one. And usually we try to do an assessment of the lung mechanics at every shift change. Of course, when you have 100 patients, it's not the same thing that when you have 20. But we try to keep it simple and reproducible, at least on the early stabilization. And then we try to individualize the settings during the day and to make plans for the next 24 hours and so on.
Thanks. And what are the kind of challenges? Why do you think these patients are getting slowly weaned from the ventilator? Is it predominantly their muscle weakness is the issue, or is it because of the lungs mechanics is the issue?
We didn't analyze all the factors on this, but my experience tells me that it's very similar to other pneumonias. So unfortunately or fortunately, it depends much on your pre-ICU status. So frail patients that are a bit older, will recover with more time if they can recover, compared to young patients that have a good muscle, good trophism of their respiratory muscles, and they can basically restart to be active again. So I would say definitely we are seeing that patients that are older and a bit more frail to start with, they find this a bit more difficult. So that's very similar, I would say, to other pneumonias, and that's certainly what we're trying to apply with knowledge from the past. What it is interesting, and is being reported by others as well, and we certainly see this in our unit, even if we've not been able to quantify or to specify why this is happening. Some patients, they seem to recover from the phase of the hypoxia, but then they go into this hypersecretory state. So there are a lot of secretions that they seem to be disproportionate compared to the disease. The disease seems to be resolving in terms of PaO2 FiO2 ratio. The PCR and the PCT are low, so the inflammatory markers are low, but the secretions are very high. And we're seeing some of the weaning being a little bit slower on this. Again, maybe it's an anecdote from my experience, but speaking with other colleagues, it seems that there is something that seems to occur in a subgroup of patients, even if we've not been able to identify why and how. And those patients, of course, sometimes they need a bit longer, and maybe sometimes they need a tracheostomy to be able to clear the secretions if they are not self-sufficient with cough and self-clearing of their secretions.
Yeah, and I think that's a very important finding that you're sharing with us, because obviously we are not seeing that many patients here, but I think there's something to keep in the mind. Now, how much is the percentage roughly? Obviously, there won't be any final data, but how many percent of patients do you think that developing a secondary bacterial infections or the complications related to ICU stay compared to previous your experience with other pneumonia patients?
I don't have the data, but I would say it seems to be similar to me, again, to those patients that have prolonged weaning. We actually are planning now to do a study to look at this, exactly because we're interested in this, in secondary infections and so on. And of course, there will be different things to look into this. It's not just about the patient and their underlying disease. I suspect that could be also organizational issues. The fact that you're managing so many patients in cohorted areas and so on. So we will have to see how many of these secondary infections are related to the patient himself or herself, or there could be also some healthcare transmitted infections, which could be also a problem, and we're aware that can be a problem sometimes in settings like this.
Yeah, absolutely. And there are a lot of things to consider. And I think your data will be so rich, which coming out of your ICUs, I guess, that will give us a lot of insight into the whole disease process overall. Now, one other thing that I'm very curious to know your perspective on is the novel therapies. And we know that a lot of the evidence is coming out slowly, but none of the treatments have shown any significant improvement in the COVID-19 outcome so far. Have you tried any of those treatments, and what's your personal experience with any of those novel treatments for COVID-19?
My view on these novel treatments is that just because we are kind of overwhelmed by the volume of patients during a pandemic, we shouldn't take shortcuts for good medicine and good research. So there has been a lot of stress on the healthcare systems, and I have seen a lot of use of compassionate use of drugs, basically. Without criticizing colleagues that have done that, I personally think it's important to keep a strong principle, which is first, do not harm. Sometimes we jump a little bit of thinking that because something is available, we want to try and give it. But remember that a lot of these novel therapies is not about only the lack of efficacy that could be a problem. It could be that there is a harm maybe in some of these therapy. That's what scares me the most, to be fair. And that's why I've not been very keen on trying new therapies. Indeed, in my unit, probably the only adjunctive therapies that we are using, despite the evidence being controversial, is steroids. But we do that on a patient-to-patient basis, and very similar to what I was doing basically in ARDS. The evidence here is even more controversial because there were some papers also on H1N1 that showed some controversial outcomes there. There is not much at the moment going on in terms of steroids in COVID, in terms of strong evidence. But I think this is the only adjunctive therapy that I would say I feel comfortable to discuss on an individual basis for my patients. For the others, I didn't start anything in my intensive care units. And I would say I think we should try these only in the context of trials. The good thing is that there are some ways to try this now. There are some very nice studies that are ongoing around the world. You may have heard about the REMAP-CAP trial, these new platforms for Bayesian adaptive trials, which I think are very interesting. And funny enough, they were put in place exactly to be ready to be tried during a pandemic. We've not been able to join them yet, but now we are thinking actually of joining trials like that, and I will be more keen to participate in this type of research or randomized controlled trials rather than just trying a new therapy. I think if you do that, it becomes impossible to realize whether the improvement is being related to the drug or to the patient himself or herself. We have to remember that despite facing a very difficult disease, this is not a disease with 100% mortality. And if you're not working with a disease that has 100% mortality, unless you're doing a randomized trial, it becomes very difficult to find if what you're seeing is association with it is causality.
Thanks, Maurizio. Thanks for sharing this such a valuable insight. I think this is really, really important principle in the medicine that without a conclusive evidence, do not harm your patient. And I think it's very important to trial any drug in the research setting rather than on a compassionate basis. So thanks for sharing that. Now, on the topic of mortality, obviously the data from Italy, which was published initially in JAMA, which kind of suggested that probably there's a 28% mortality in ICU patients. Now, what we're seeing in the UK from the ICNARC data is roughly around 50 to 60% mortality in ventilated patients. And that's obviously given the caveat that there are still many patients still in the ICU on mechanical ventilation. Why do you think there is a stark difference between the mortality in these two countries, which are apart?
I'm not sure there is that difference, to be fair. If you read the paper carefully, you will see that we reported, because we wanted to report the data very early to share with the wider community. But when we reported the data, we reported data roughly on 1,600 patients, of which roughly 90%, a little bit less, were invasively mechanically ventilated. But the mortality was the mortality at that time. So many patients had just entered the intensive care unit. And indeed, roughly the number that we are seeing even here in the region is for 28 days a month after ICU admissions, I think is stabilizing around 50% mortality. We've not published that yet, but that's the data we were seeing. We're happy to share this information, of course. So I suspect for very sick patients, and again, older patients have worse outcomes than others, I would not be surprised if mortality stabilizes on those figures. Of course, it depends a lot on the type of patients and on the settings. I'm sure we will see some variability between patients and maybe between healthcare systems. But I think this is a serious disease, and long mortality after ICU admissions is likely to be a high number, unfortunately.
Yeah, and I think it's still quite early days to get the whole picture of the pandemic, I guess. But that 50 to 60% is a still quite concerning number. Now, a lot of data came on the proning helps, and ECMO is not that useful. Is there any reason, particularly, why we are seeing the difference with proning and why we are not getting much improvement with ECMO? Is there any particular reason that you think?
I don't know how to answer with that because we do a lot of proning and our ECMO beds were used, but we didn't increase significantly the capacity for ECMO because we really had to work on increasing the capacity for advanced respiratory support in terms of invasive mechanical ventilation. What I would say is that, again, using the evidence from the past, when the PaO2 FiO2 ratio is below 150, I would say you need to have a good reason for not using proning in the acute setting. So we use quite a lot of proning here. Now, whether the improvement that you see in the acute physiology, which was very constant and with a significant increase in PaO2 and therefore, better protective ventilation during the proning sessions, is translated to longer benefits, I don't think no one knows. But having some strong evidence from ARDS and thinking that it makes also physiological sense, I think there are two important rationales to use proning, and we use quite a bit of proning. Again, there are organizational aspects here. If you have 100 patients and one nurse looking after 6 beds, maybe it's more dangerous to do proning than to do something else. We were lucky to be able to maintain a good ratio of nurses to patients in my unit with the help of other nurses. So not everyone was an experienced ICU nurse, but we had a kind of help, and so we were able to maintain a 1 to 2 roughly nurse to patient ratio, but not everyone was an ICU nurse. So we used proning probably a little bit more at the beginning, and then we started to see that we could manage the situation also in a more conservative way sometimes. But again, it's about the clinical picture in front of you for this patient, but also the organizational aspects and how your resources are stretched. And it goes back to what we were saying before, is first do not harm. So you need to do something if you're thinking that you know how to do it well and you're unlikely to harm your patient.
Thanks, Maurizio. And another kind of controversial aspect was about the CPAP with helmet and mask and whether early intubation is better than non-invasive ventilation. Now you started seeing obviously more patients are still coming in your ICUs with COVID-19. Have you changed your approach or like trialing the non-invasive ventilation first and then moving to intubation, or what's your kind of preference there in your ICUs?
So our approach, and again, goes back to how our intensive care units were organized. So again, the level 3 units, they took all the invasively mechanical ventilated patients, and then some patients that we wanted to try some CPAP or non-invasive ventilation, mainly CPAP, I would say. In Italy, we do make this difference. I know that often when you read papers or when you talk about this, the two words are used interchangeably. However, and I will come back to this in terms of physiology, I think CPAP in this case is different from NIV. Usually CPAP means that you need a bit of pressure and some oxygen to try to improve the oxygenation. And we found that in some patients is very beneficial. They do feel okay. Clinically, they don't feel tired. They can read. Some of them, they were on their phone. So we did manage quite a bit of CPAP in that way. We found out that when patients were getting tired, so giving them some support really to improve also the work of breathing, and they were starting maybe to become hypercapnic or to become very tired from the respiration, we actually kind of find that the non-invasive ventilation was almost like a trigger to intubate. So as long as you were managing okay on CPAP and being comfortable, the situation was getting better and the patient was not too tachypnoic. We did manage a significant group of patients just on CPAP, and some of these patients, quite a few of these patients got better. We are trying to quantify this with a study that again is under completion. But we decided not to intubate everyone if we thought that in that patient CPAP could have been beneficial. So we had a significant group of patients definitely managed on CPAP. Much less non-invasive ventilation. So when you're applying 2 different levels of pressure, we kind of find that if we thought that intensive care was appropriate for the patient, we would have intubated the patient very early. And of course, it goes back to what we know from the past. There's no point of tiring a patient on non-invasive or on CPAP. So if you see that the patient may be getting tired, really, you should get on with the intubation and not delay it.
Thanks, Maurizio. And another interesting data came from the autopsy findings and also some of the imaging finding that these patients develop a lot of thromboembolic complications, maybe stroke or maybe microvascular thrombi in their lungs. And the question was whether we should anticoagulate them therapeutically, given that they're at very high risk of developing thrombotic complications. What's your experience so far, and what's the strategies that you are implementing in your ICUs?
So we actually published very recently on thrombosis research with one of my colleagues and expert on the coagulation here, Corrado Lodigiani. You may find the paper is just come out. We did find indeed that the incidence of thrombosis is high. However, let's remember that we are seeing a sepsis here. It's due to a virus, but it is a sepsis. It's an inflammation there is there. And we know that thrombosis, it's very often the end pathway of inflammation. So there has been a lot of speculation about, because we were finding a lot of thrombosis, whether we should anticoagulate everyone. We decided, first of all, to quantify the problem. And indeed, we found that there is a significant group of patients with thrombosis, but we didn't think that there was enough evidence to decide to anticoagulate everyone. So in our series, everyone had a thromboprophylaxis in the ICU, so 100% of the patients had that. The majority of patients hospitalized were receiving thromboprophylaxis. I think it was around 75%. And some people were even arguing why not giving thromboprophylaxis at home or anticoagulating people at home. Again, I would go back to what I was saying before. I'm not sure we have evidence to suggest that because we found that there is a problem, preventing the problem with anticoagulation could do good rather than harm. And remember that when you decide to anticoagulate someone, if you are really going down that path, you should think about anticoagulation for some weeks, sometimes for some months. We don't know if that's beneficial or not. So we are basically, at the moment, still thromboprophylaxing everyone. And of course, you have to do it with the right tables for weight and other risk factors and so on. But we are not going for full anticoagulation for everyone. We are doing that only if we think that the risk is extremely high or if we identify deep venous thrombosis. Again, even for these, I know that there are some trials ongoing at the moment. Maybe they will inform us a bit more. But basically, we're just very careful. Maybe we look for thrombosis a bit more often than in the past. We've realized that it can be common, but it doesn't mean that everyone will have a thrombosis. So we will search for it more commonly now, and then we will decide how to manage that.
Yeah, I think that's important. I read that paper from thrombosis research, and I think that's a valuable insight again. Now, another question was about the neurological complications. And again, probably the mechanism was because of this microvascular thrombi. Now, in terms of your experience, all these patients who are recovering from the early acute illness, are you seeing any prevalence of neurological complications in these patients? Are they prone for more delirium, or what's the kind of situation in your ICUs?
You may have seen there was one or two papers that came out on this recently, and indeed the neurological complications are frequent in this patient. However, I don't think we made the final connection here between what we are seeing is part of delirium into a multifactorial process into a very sick patient, or if there is an organic component for this delirium of the neurological complication. We are seeing some of these complications. We've seen them also in my intensive care unit. It does not seem that there is a direct effect of the virus, at least not the ones that we've seen. So not that it's the virus there, but it could be related to the fact, it is related to the COVID problem, so to the fact that you're infected with this. Again, I think we need quite a bit of research to understand what is the impact of this. We know that they are frequent, but at best, I think we should apply the bundles for prevention of delirium and for making sure that our patients don't get this. I don't think we have a treatment to prevent this as a pharmacological treatment at the moment.
Yeah, thanks, Maurizio. And one of the kind of key challenges that this pandemic has brought to us is the organizational challenge. And I think your initial podcast was very insightful as we kind of learned a lot from that podcast in terms of how to get prepared. Now, obviously, the second wave of COVID-19 is still on the radar, and it's still not that we are not completely out of the woods yet. Um, what are the kind of key lessons from your first experience, and will you do anything differently if we have to face this surge in number of cases again?
Well, if we knew on the 21st of February that we were going to see so many patients, probably some weeks before we would have made the surge plan and how to escalate the plan and how to go into the, to the volume of beds that you need to cope with this. Now it is something that we've done, and every institution has the de-escalation and de-escalation plan in place to know how to deal with this. To be honest, the biggest lesson for me was really to realize that this is a situation during a pandemic where it's not just what you can do in the hospital, but really you need to pass these messages out there, and you need to work with health authorities and government really to explain that just increasing capacity, if you have a peak as bad as the one that we had and some other cities had, you're not just going to cope with it just by increasing capacity. The controlling of the viral transmission is so important. That's why today is a big day for us here, releasing the lockdown with some social distancing rules, and we really want to see if we will be able to control the transmission this time. And this time, I don't think we have an excuse. The first time it was a surprise. I don't think we can say that this time we will have a surprise. So we are doing this in a very controlled and gradual way. One big learning was definitely also that this is not just about ICU. This surge capacity, the ICU is the kind of the tip of the iceberg, but there is a whole organization in the hospital, beds for other acute patients, patients that will live in intensive care. Everything has to go around that. And we found, at least in my hospital, was having a crisis unit that was working very closely every day. Clear communication, clarity around common goals was very good to keep the teams aware of what we wanted to achieve. And it was not just about doctors and nurses. It was doctors and nurses, the chief operating officer, the chief executive officer, the medical director, the engineers. I remember spending, some days realizing that there is a maximum oxygen flow capacity in some walls, and therefore your ideal situation may have to change because there are some actually structural limits in your building. And again, this is something that if you don't work as a team, you will not find out.
Yeah, absolutely. And fingers crossed that you will not see the same surge again, and hopefully the situation will be much under control in next few months. Now, you brought a very important point about the teamwork. And when we work in the team situation, it's very important to look after each other's well-being. And even in Australia, getting ready for pandemic was quite exhausting, I must say. Now, you guys actually gone through this whole process of not just preparing, but actually dealing with a massive surge. And you're still dealing with quite a significant number of patient population there in ICUs and in hospital. How are you coping in terms of your well-being, and what are the kind of strategies that you have put in place to look after your staff and yourself?
Well, first of all, even during the surge, you have to try to look after each other, as you were saying. And one of my teachers, and one of the best talks I heard about this from a course I did at the Harvard Medical School, was from Amy Edmondson. She's a professor of business school, and she talks a lot about psychological safety and teams and teaming. She gives some great examples, and those for me were great learning to try to bring to my team. So it's very important to, in a moment like this, where you will have a lot of people that never work together because you need the help of doctors and nurses from other parts of the hospital. You need to create a way for everyone, first of all, to learn each other names. It seems a simple thing, but it's not so simple when you're there. To feel comfortable to teach and also to ask, and when you are out of your comfort zone. So to create this climate of psychological safety, I find it very important, which does not mean that you have to be just good to each other. You still have to try to keep standards, which are clearly different from a moment where you are not having a situation like this. This is about saving as many lives as you can, but it's about trying to get as high as you can on the quality of the standard, but again, looking after each other. It has been tough. It has been tough because it's not only about how you work and the hours that you work. It was a very different environment for all of us. You know, we spent the last few years bringing families at the bedside, increasing the hours that families could visit in our units. Some units around the world, they were already doing 24/7 visiting times. And suddenly, because we have to control the transmission, we don't want to bring risks to the families themselves. We didn't allow them to come in at the bedside. That was probably the most stressful part of all of this. So there were a lot of emotions. You know, when you had a mom or a grandfather being extubated and able to speak or to video call at home, of course, that's a great moment for everyone. You have to celebrate that, especially in moments like this. But there were also moments in which, you know, we were the only ones holding hands to people die in the hospital. And often people say, people die in the hospital alone, and we just refused that. We wanted to be there at least for the patient. So we were not accepting that the patient will die alone, but it is stressful. You are maybe going to be the last person the last person that the patient will see or hold hands, and normally should be the family there. So, you know, you become a little bit the family for those patients, but it is something very strong for all the team. And speaking with my team members, whether doctors or nurses, everyone tells me that that's been the most difficult part for them, for all of us, really.
Yeah, and I can only imagine how stressful it would be for even for patient families and entire team. And I think you guys did an amazing job, and all of you must be congratulated. And I am our best wishes are with you and your teams in these difficult times. Now, you mentioned a very good point in one of your talks about creating the healthcare armies for the future. The context for that was when Italy was fighting with this battle. Most of us were sitting and preparing, but we didn't face COVID-19 pandemic, and there was probably that window where we could have mobilized some of the healthcare workers from other parts of the world to Italy to contain the outbreak, or in fact help you guys to get some breather. Now, is there a kind of future plan in place within the European Union or within Italy to kind of facilitate that if this happens again?
Look, I'm not aware of an official plan for this yet, but you're right. I think what we learned from this pandemic is it can affect the whole world, but very often it will not be everywhere at the same time. So, that could be opportunities there for the future. And I do believe that we, as a community, not just of ICU doctors, but ICU doctors will be the ones dealing with, a possible pandemic. And the most difficult pandemics will always be the ones with a virus that is easy to transmit and that gives acute respiratory failure. Let's face it, it was the nightmare that we were all aware it could happen. No one was expecting, or at least we were all hoping it would not happen in our careers. I think we have to be honest, this has been a wake-up call for every healthcare systems. Whatever people say, I don't think we were ready. I was not ready. I don't think we were ready, and I don't think the global communities and the global community of countries were ready. So, yes, I talked about developing an healthcare army. I don't know if army is the right word, or team, or something to fight, something like this in the future. But yes, I think it would be good to think about surge capacity for acute problems like this in the future. I think we've been warned once. It's the first time that we have so many ways to communicate through the internet that we can really think about this. And if we were surprised once, I wouldn't like to be surprised again twice in my career, whatever is going to be the next pandemic. And let's face it, this pandemic can stay around for a while. No one knows how it's going to evolve. No one knows if the susceptible population is really going to be everyone that is not being infected yet, or hopefully something less. No one knows if we really have to wait for the vaccine to completely get rid of this. It's too early. We don't know if it's going to have a seasonal effect or not. So we need to get ready for this to be around for a while. And the good thing I would say is that the scientific community really got together. I think, we put away all borders. Even, the fact that today you're doing this podcast is great. I think there's just not enough of this. But the action plan to have an arm that could really bring a real action to different places that we didn't have. And I suspect we have to think about something like that for the future.
Absolutely. And I think it's really important to think beyond boundaries because often we like to work in silos and within ICUs and within departments and within our countries. But I think this pandemic has clearly woken us up that we have to think broadly. And if you see the frequency of pandemics is becoming a bit more frequent now, because after 2003, there was 2009 and then 2016 and then now 2020. So again, this duration between the pandemics is getting probably shortened over the period of time. And I won't be surprised if we see another pandemic in the near future. So I think there are a lot of lessons to learn from this pandemic, which we can implement for the future. Moving forward, and when you will have your business as usual back in your ICUs, do you think that you will change some of the things that you used to do before the pandemic, and you think that will look very different after the pandemic in your ICU?
It's a very good question. I think what this pandemic has taught me is that really there is never enough work that you can do to improve your practice and your team and your working environment. There's never enough, because I came to this new job 2 years ago, and I was just in the phase where I was happy to how my team was working, and the changes that we implement, the way we were working within the hospital, and also the way we were trying to help, and bring intensive care wherever was needed in the hospital, to be very clear about goals of care with patients and their families. We did a lot of work of this in the previous 2 years, and I think my team has been amazing. It was really incredible how we got together. But I would say if I had to think about the solution just at the time of the pandemic, it would have been even more difficult. So really, we shouldn't improve and we shouldn't do all these things just when there is a pandemic. Improving how your team and how you deliver intensive care, how we deliver intensive care within intensive care and outside the walls of intensive care, it's a continuous improvement process and can only bring you advantages when something unexpected comes to your hospital.
Yeah, and I think it's a very key message that we constantly strive to improve, and we should not just stop here because we survived. But I think we should take these lessons and change our practices for the good of society and for intensive care community. So I think that's a very great message, Maurizio. So thanks, Maurizio. Thank you very much for sparing valuable time. And I know you're very busy dealing with logistic issues, organizational issues, treating patients, and also with your own family. I must say you sacrificed a lot of things for during this period. So thank you very much from the entire intensive care community.
Thank you, Cecconi, for hosting me, and good luck, everyone.